Hello everyone, this is Nicole Freeland, and today we are discussing Chapter 31, the musculoskeletal system. Your objectives for this chapter are to describe causes of musculoskeletal disorders and ways to prevent them, distinguish ways in which older adults can increase musculoskeletal strength and protect bones, compare the procedure and nursing care for the following diagnostic tests: CT, MRI, bone scan, arthroscopy, and arthrocentesis. Perform an assessment on a patient with a musculoskeletal disorder, and describe and use measures to reduce the chance of contracture for patients with musculoskeletal injuries. We'll do a quick anatomy overview of the musculoskeletal system. Our musculoskeletal system consists of bones, joints, cartilage, ligaments, tendons, and muscles. A joint is the point between two or more bones. Ligaments join the bones of a joint together. Tendons are the connective tissues that provide joint movement. And cartilage is a semi-solid gel-like material that provides cushion for our joints during movement. Functions of bones. Our bones provide our body's shape. They support and protect internal organs like the bones of our rib cage, protect our vital organs such as our heart and our lungs. The bones contribute to movement of our bodies. Red bone marrow produces red blood cells, white blood cells, and platelets. And bones also store and release minerals such as calcium and phosphorus. The function of our muscles are to contract and relax, to provide movement and joint stability to our body. They also help us to maintain a proper posture, and they also provide our body with heat. Some common age-related changes that we will see in the musculoskeletal system as we age is the ossification of our bones, or the replacement of cartilage. Our bone density also decreases as we age. Loss of bone mass, known as osteoporosis, also occurs with aging and is more severe in women. Our bones often become brittle, making us more susceptible to fractures. The bones, when they are fractured, heal slower due to decreased mineral exchange within our bones. Oftentimes, kyphosis may occur. This is the thinning of the intervertebral cartilage and then the collapse of the vertebra, which results in a shortened spinal column and sometimes a curvature of our spinal column. This is why an older adult's height decreases as they age. We may also experience joint stiffness. This is because cartilage thins and erodes from years of use. And then crepitation is a result. This is actually a grating sound of the joints. If you've ever helped an elderly adult out of bed, you can actually sometimes hear them creaking. This is known as crepitation. There is also decreased muscle mass as we age. The tendons may shrink and become sclerotic, slowing the movement of our body. And there is impaired circulation, and there may be accumulation of metabolic waste, within our musculoskeletal system, and the consequence of this is people will often experience muscle cramping and pain due to impaired circulation and the accumulation of waste. So we will do a general overview of musculoskeletal disorders. Causes of these disorders include disease, trauma, malnutrition, and then the aging process itself. Trauma can result in bruising, strain, sprain, or fractures. Poor nutrition deprives the body of sufficient calcium and phosphorus needed for strong bone growth. Inadequate protein intake can cause muscle wasting. So it is important to educate our patients over the need for adequate amounts of calcium and phosphorus. Some good foods to recommend for these sources of minerals are dairy products such as cheese, yogurt, and milk. Green leafy vegetables do contain calcium, but they are not as easily absorbed. Some non-dairy sources of calcium are sardines, salmon, tofu, figs, and dried apricots. It's also important to note that magnesium and vitamin K are also required for healthy bones. These are usually absorbed or obtained through a diet that contains meat and green vegetables, such as spinach. To help our patients prevent musculoskeletal disorders, it is important to educate them over the need to maintain active throughout their lifespan. So regular exercise at least 3 times a week is essential to maintain orthopedic health. Weight-bearing exercise throughout the life is needed to maintain bone mass and can decrease the incidence of osteoporosis, increase muscle strength, increase mass, agility, balance, and coordination, which may prevent infalls and fractures. It's also important to educate our patients over proper body alignment when lifting and moving objects, especially heavy objects. We need to use large muscle groups to prevent muscle strain and sprains. A great form of exercise that has been found to be beneficial to the elderly population is actually Tai Chi. This increases mobility, strength, balance, and flexibility, and is low impact. Also, we can educate our patients over smoking cessation. So smoking itself has a great effect on our musculoskeletal system. It increases the risk of osteoporosis. It can increase the risk of fractures. It can increase the risk of exercise-related injuries. It has a detrimental effect on fracture and wound healing in that it slows healing time. And it has an effect on athletic performance for individuals related to their respiratory system, and can be associated with low back pain and rheumatoid arthritis. Some diagnostic tests and procedures that are related to musculoskeletal disorders. First, I'll go through the laboratory tests. The first one is calcium. Please know the normal value of calcium. Elevated calcium levels extend immobilization and metastatic bone disease. Phosphate levels, know the normal value of that. These are elevated when calcium levels are high. Alkaline phosphate, or ALP, may be elevated and indicates Paget's disease or bone metastases. Creatinine kinase. There are two different normal values. One is for males and the other for females. This may be elevated when muscle damage occurs. Uric acid, the normal ranges for those are different from male to female. This is elevated when gout is present. We may draw a rheumatoid factor to help us diagnose rheumatoid arthritis. And then the other test is an ANA. Elevation of ANA may also indicate rheumatoid arthritis or other autoimmune diseases. You also need to be familiar with diagnostic procedures. These are listed on table 31-3 on page 723 and 724. Please know the purpose of the test, the description, and the nursing implications. Your beginning of lecture activity will be to define your assigned test, tell us the purpose, description, and nursing implications of that test. Problems related to the musculoskeletal system. Immobility itself can be caused by neurologic injuries or disease that cause long-term immobility, or we can have trauma that occurs that causes short-term immobility, such as strains, injuries to our joints, fractures, back pain, sometimes surgery. So it is important to assist our patients with early ambulation and rehabilitation measures to ensure that they remain mobile. One thing that we can do is to actually perform gynometry or gonometry, which measures the individual's range of motion. Contractures are the shortening of skeletal muscle tissue that leads to disformity. We can prevent contractures through helping our patients to maintain a range of motion. So when our patients are not able to perform range of motion exercises themselves, we will assist them with range of motion exercises. These need to be done minimally 3 times a day. Ankylosing is the permanent fixation of a joint. This may be caused by trauma, immobility, or sometimes surgery. And then loss of muscle tone can also be a result of immobility. Again, we need to assist our patient with range of motion exercises at least 3 times a day to prevent loss of muscle tone. Pain may also occur for these patients, so it is important to provide adequate analgesic medications, sometimes heat and cold or even topical pain relieving medications, so that our patients are able to perform range of motion exercises adequately. Nursing management for the musculoskeletal system includes obtaining a thorough history from our patients. So when you are interviewing your patient, you would want to inquire about any recent pain they are experiencing or chronic pain. Have there been any recent changes to their joints that they have noticed? Are they stiff or swollen? We need to ask if they have any restrictions to their range of motion. Have they had previous trauma or surgeries? Do they have any underlying diseases that may affect their musculoskeletal system, such as those like diabetes, sickle cell disease, and then other neurological disorders such as lupus or chronic metabolic diseases? We need to know what medications they are taking, if they are often fatigued. Do they have any problems performing ADLs? And then we need to ensure safety within their home environment as well. Then you will perform a physical assessment. When you do this, you need to note your patient's posture, their gait, their balance, the overall mobility of your patient. Are they using any assistive devices or splints or braces? How good is their range of motion? Do they have full range of motion? Is their strength adequate, or do they need assistance with something like a walker? Is their spine aligned, or is it not? Is there tenderness to that area upon palpation? Do they experience frequent back pain? How do their joints look? Are they swollen? Are they normal? And then again, are they able to perform ADLs? So nursing, diagnosis, and planning, caring for mobile patients, it does require careful planning on the nurse's part. It's oftentimes best performed with 2 or more staff. Moving these patients is strenuous. Bathing these patients is strenuous, especially if they have an immobile limb. It will take quite a bit longer for you to bathe your patient. And then we also need to ensure that we are planning regular intervals for toileting for patients who are unable to get out of bed, those who are bedbound. This is because we want to prevent further injury to our patients. The skin integrity is very important for these patients and can very easily be broken down within a matter of hours if proper care is not provided. If you have a bedbound patient, you need to ensure that you are repositioning your patient at least every 2 hours. More is better. However, if you work night shift, you do want to ensure that your patient can get as much rest as possible, which really is not something that is done in the hospital. They are often interrupted. One reason for being interrupted throughout a sleeping period would be to reposition them to ensure that you are avoiding any pressure ulcers to that patient. It's important to remember that approximately 30 to 40% of inpatient safety incidents are directly related to falls. The older adult is vulnerable because of the changes related to aging. We need to conduct a fall risk assessment and initiate fall precautions per your facility's protocol for our elderly patients. Some physiological consequences of immobility include that upon our cardiovascular system. Immobility decreases cardiac output with reduced force of cardiac contraction, and immobility causing decreased use of leg muscles leads to the possibility of venous stasis formation and blood clots. Our respiratory system is affected because reduced lung expansion and consequent reduced gas exchange with potential for atelectasis and pooling of secretions occurs with immobility. So we need to remind our immobile patients that they need to be coughing and deep breathing at least 10 times an hour. They may also use an incentive spirometer. As the nurse, you can actually implement that intervention. You simply call cardiopulmonary services and ask them to bring an incentive spirometer to your patient's bedside and to educate them over the proper use of the incentive spirometer. This will help to maintain proper lung function and expansion and can decrease the incidence of respiratory infection. The musculoskeletal system is affected by prolonged immobility, leading to the decrease of muscle mass and atrophy such as contractions. Demineralization within the bones can also be seen, and osteoporosis may also occur if immobility is long-term. The integumentary system can be affected due to skin breakdown from pressure ulcers and reduced oxygenation from blood flow. So the less that we are moving, the less our circulation is affected, the less the oxygen is flowing throughout our system and reaching the muscles of our bodies. The gastrointestinal system is affected because when we are immobile, the slowing of peristalsis occurs. Our appetite may decrease, and the ability to assume an upright position for excretion may also result. The urinary system can be directly affected because calcium from bone increases in the blood from immobility, bladder tone decreases, and more time in a supine position from immobility leads to urinary stasis, which can result in infection, renal calculi, and urinary tract infections. And then the psychological effects of immobility are very great. Feelings of helplessness and hopelessness, boredom, depression, a disturbed body image, anger, anxiety can all be results from immobility. If you as the nurse are caring for someone that is immobile, especially those that have been long-term immobilized, we need to provide them with as much independence as they are able to have. Oftentimes that means that we will discuss their care with them, and we will allow them to make decisions regarding the care they are receiving so that their independence remains as intact as possible. You may take care of paraplegic patients or quadriplegic patients who seem very demanding of you as their nurse. A lot of times this stems from the psychological issues related to immobility. So it is important to remember it's not personal. It is the result of this person's disability, and we need to help them maintain a level of independence as much as possible. Prevention of injury to our immobilized patient is extremely important. The first intervention that we can use to help prevent injury is positioning and repositioning of our patient. Repositioning, as I stated before, needs to be done at least every 2 hours, if not more. These patients, if they are able, need to frequently get up to the chair to prevent pressure ulcers, circulatory problems, respiratory and urinary complications as well. It's also important to remember that the reposition of joints needs to be performed frequently to prevent joint deformity. When you are repositioning your patient, please look for signs of muscle tightness and resistance in the joints, and also observe their skin for any signs of pressure ulcer related injuries. Also, it's important to note that for paralysis, there are a couple different types of paralysis. One is flaccid, the other is spastic. Flaccid paralysis is where the patient is immobile and their limbs are very much like dead weight. For these patients, we would reposition them differently than those with spastic paralysis. For flaccid, we may provide our patients with a footboard to prevent foot drop. However, if we do this for a spastic paralysis patient, this may actually cause muscle contractions and then aggravate the spasticity. So we may use a cradle to relieve pressure to their feet. It is important also that if you are implementing measures to prevent foot drop, that you frequently observe the patient's heels for any signs of pressure ulcer related injuries. Lifting and turning the patient. When we work with orthopedic patients, all movements must be gentle and firm. When moving or turning the patient, we need to make sure that we have adequate help from trained personnel to prevent injury to the patient and ourselves. We need to discuss what is to be performed to the patient before we perform the lifting and turning. That way, any assistance that the patient may provide can be done. Exercise will include range of motion exercises, both passive and active. These need to be planned and carried out as soon as feasible after decreased mobility occurs to ensure adequate muscle tone and prevent contractures. Range of motion exercises should be done, again, 3 or 4 times a day. And then there's also isometric exercises. This involves generating tension between 2 opposing sets of muscles, such as flexing the lower arm while using the opposite hand to try to extend it. You must be aware that isometric exercise may be contraindicated in patients with hypertension, increased intracranial pressure, or congestive heart failure, because isometric exercise causes a significant increase in blood pressure and heart rate. Gradual mobilization is the progression of mobilization. Assessing the patient's ability to move their limbs, turn themselves in bed, transfer themselves from the bed to a chair and back again, and then to stand and walk. These measurable signs of independent movement represent various stages to which the patient can gradually progress. Setting goals for progressive mobilization must take into account the pathologic condition causing the immobility, any contraindications to movement of a body part, such as a non-weight-bearing extremity, and the ability of the patient to understand and take part in carrying out in the rehabilitation activities. Therapeutic measures that are used for immobilized patients include specialized beds. There are beds that help to prevent pressure ulcers. These are oftentimes called low air loss mattress beds. And then there are also beds that are fluidized, that are used for various types of immobility, that also help to prevent pressure ulcers and sores, because these conform to the body's weight and the air shifts as the body's weight is redistributed. For patients in cervical traction, there is a special type of bed known as a rotorest bed. This turns the patient many times a day, about 300 times a day. It provides passive exercise and it stimulates peristalsis without the risk of injury to the patient. Use of slings, splints, and braces may also be necessary for some immobilized patients. A sling supports the specific joint. It should be positioned so that the fastening at the area, like the neck, does not rub on or press against any vessels of the neck. When a splint is applied to an extremity, it should support the joint that it is to immobilize. It should fit properly without impeding circulation, and it should not slip out of place easily. It also should not cause increased pain. So for a patient that is in a splint, we need to frequently monitor their circulation. One way we can do this is through capillary refill, and then observation of skin color and temperature. Physical therapy may be prescribed by the healthcare provider to assist the patient to regain mobility, increase strength after immobility, decrease pain, and prevent injury. Specific exercises, ultrasound, electrical stimulation of muscles, massage, kinetic taping, and heat or cold may all be used during physical therapy. They will also instruct the patient on the proper way to use crutches, to use a cane, or certain types of walkers, so that it is safe for these patients to ambulate with these devices. Occupational therapy is used to assist patients to perform activities of daily living using adaptive equipment and alternate movements. They help the patient to learn new ways of getting out of the sitting position, getting in and out of the car, bed mobility, cooking, eating, dressing, and even showering for these patients so that they are able to be as independent as possible. As I stated before, teaching ambulation techniques with assistive devices is largely done by physical therapy. However, it is important for us as the nurse to know the proper way to use these assistive devices. There are several different ways to educate your patient on the proper ambulation with crutches. That table is listed on page 730. Please refer to those different types of gaits and know what they are. The type of crutch that is to be used will depend on the extent of the disability or paralysis and the patient's ability to bear weight and maintain their balance. If the crutches are too short or too long, the patient will have problems with moving and shifting their weight. When walking, the patient should straighten the elbow and the wrist during weight bearing. The muscles of the arms, shoulders, back, and chest are all used in manipulation of crutches. So oftentimes if the patient has surgery scheduled, they will begin working with physical therapy several weeks before the procedure to learn the proper use of their assistive device. Safety measures where crutches are concerned. Height is important when they are fitted to their crutches. When the patient is in the standing position with axillary crutches, the axillary bar should be 2 finger breadths below the axilla. The elbow should be flexed at a 30-degree angle when the palms of the hands rest on the hand grip. It's important for the patient not to rest their body at the axilla on top of the crutch. Body weight should be borne by the arms on the hand rests of the crutch. And then special maneuvers need to be taught to the patient as well, such as how to rise from a sitting to a standing position, how to go up and down the stairs, and how to walk down the stairs. You can review that table on page 731. That concludes chapter 31. Here you will see a list of questions. These are your post-lecture questions for the day. Please answer these questions and submit your responses to Moodle. Thank you all very much for your time, and I hope you have a wonderful rest of your day. Bye-bye.